times we spend so much of time thinking all the things that we have to do throughout the day and throughout a plan that we have made for that particular subject. Okay, this, then this, then this, then this. And by the end, we are so overwhelmed and so tired mentally that we are so scared to start. So once you have a rough sketch of what you need to do, don't keep having a look at it again and again and again. Just break it into small pieces and focus on only one step at a time. And then forget everything that is left, all the things that you need to do next and next and next. Just forget it. Just focus on what you have to do at that particular moment, just one step at a time. And yes, that is all that you need to get to your goal. So with that, we start with a very important topic of the year, the complications of otitis media. Complications of otitis media. Do I mean only squamous otitis media? Or can it be acute otitis media also, or chronic mucosal otitis media also? Yes, it can be anything. Yes, complications in chronic squamous is more common than in chronic mucosal otitis media, because in chronic squamous, you already know what do we have? Yes, we have cholesteatoma. What property does cholesteatoma have? Yes, of bony erosion because of enzymatic activity. So there it is more common than mucosal. It does not mean that only in the squamous we can have complications. So yes, complication can happen in squamous, in mucosal, also in acute otitis media. How in acute otitis media there can be complication? Just think of it. Yes, there are natural openings in the middle ear. There are natural openings. So it can occur because of the infection going through natural openings. So we have the oval windows through natural openings. Like oval window, we have round window, we have aditas. Yes, so it can go to the adjacent structures through the natural openings. It can go through congenital dehiscences. Congenital dehiscence. Congenital dehiscence, very, very common is congenital dehiscence of the fallopian canal. There can be congenital dehiscence of the tegment tympani. There can be congenital dehiscence in between the middle ear and the jugular belt, that is in the floor of the middle ear, from where infection can go to all these adjacent areas. Or there can be dehiscences which have been created following trauma. And this trauma can be iatrogenic or non-iatrogenic, following surgery or non-surgical trauma. And yes, very, very important, we already know that we can have bone erosion, and that occurs in squamous, chronic squamous otitis media. And yes, it can also go through venous thrombophlebitis. Venous thrombophlebitis, it can go anywhere. It can go intracranially, it can go to the meninges, it can go to the temporal lobe, anywhere it can go through venous thrombophlebitis. So yes, the infection from the middle ear, from where it can go to all the surrounding areas through all these routes, but where all can it go? Yes, it can either go outside the middle ear but still be localized to the temporal bone. We know what the temporal bone is, right? So when the infection from the middle ear goes outside the middle ear but it is still localized to the temporal bone, we call it as intratemporal. We call it as intratemporal, or we call it as extracranial. Extracranial. So in the intratemporal complications, where all can the infection go? It can go from the middle ear, it can rupture the tympanic membrane. So there can be perforation of tympanic membrane. When it goes medially, where does it go? Into the inner ear. What will that be called as? Labyrinthitis. In the middle ear, it can involve the very, very important nerve. Which nerve? Facial nerve. So there can be facial nerve palsy. If the infection from the middle ear goes posteriorly, where does it go posteriorly? Yes, through the aditas, it can go to the mastoid. That can lead to mastoiditis. And when the infection from the mastoid, the deep part of mastoid is formed by the petrous part of temporal bone. Do we know that? Yes, we know that the mastoid is formed superficially by the squamous and deep part by the petrous part. So which means that the mastoid air cells automatically communicate with the petrous group of air cells. So if the infection from the mastoid goes into the petrous group of air cells reaching up to the petrous apex, then what is what is known as petrositis. So all these complications are known as intratemporal, or they are known as extracranial because they are still outside the intracranial cavity. So in the intratemporal complications, we can have perforation of tympanic membrane. If it goes medially, there can be labyrinthitis. In the middle ear, there can be facial nerve palsy. There can be infection going to the mastoid, that is known as mastoiditis. Or it can go to the petrous apex when it is known as petrositis. So in the intratemporal complications, the most common complication that follows acute otitis media is a perforation. Perforation of tympanic membrane is most common, followed by mastoid abscess, followed by mastoiditis. Whereas following chronic otitis media, the most common complication is a mastoid abscess. When the infection goes intracranially, we can have multiple intracranial complications. The intracranial complications we will do in a while once we have done the intratemporal complications. So the first intratemporal complications let us do is mastoiditis. Now the perforation of the tympanic membrane, we have already seen that following a acute otitis media, when the perforation occurs, how it heals by how many layers? Yes, 2 layers. If it does not heal, then it leads to which condition? Yes, chronic otitis media. So all that we already know about the perforation of the tympanic membrane. So if the infection of the middle ear goes posteriorly, that is mastoiditis. And mastoiditis is after perforation. The next most common complication following acute otitis media is mastoiditis. And what we need to know in mastoiditis, what is occurring in mastoiditis is exactly what occurs in acute otitis media. So you tell me what is happening in acute otitis media. I will tell you what is happening in acute mastoiditis. Done? Okay, so what is happening in acute otitis media? So here we have the middle ear. Here we have the eustachian tube. This is the posterior wall, that is the connection, the arditus. Here we have the arditus. And yes, this is the mastoid, right? So you will tell me first, yes, the acute otitis media. Tell me, where is the infection coming from in acute otitis media? Yes, from the pharynx. So most common organism causing acute pharyngitis is the same that causes acute otitis media. Quickly tell me the organism. Yes, it is Streptococcus pneumoniae or pneumococcus. Very good. So it is Streptococcus pneumoniae. So the infection goes first in the eustachian tube. Next, the infection reaches the middle ear. So when the infection reaches the middle ear, what happens in the middle ear cavity? Yes, tell me quickly. Yes, the infection will cause hyperemia of all the mucosal lining of the middle ear, because of which there will be exudation of fluid in the middle ear cavity. What is this known as? This is known as stage of hyperemia or presuppuration. Next, what will happen? This fluid that is collected will get suppurated. It will put pressure on the tympanic membrane. Tympanic membrane will rupture and the pus will come out. Yes? Very good. Now, I will tell you what is happening in acute mastoiditis is exactly ditto the same. Now, here, the only difference is that first, all these changes were occurring in the middle ear. Now, they are occurring in the mastoid air cells. So, in the mastoid, we know there are multiple air cells. Multiple air cells. Yes, the largest mastoid air cell is the deepest, that is the mastoid antrum, right? So now what happens is the infection, when the patient's immunity is less, then the infection does not remain in the middle ear. Through the arditus, the infection goes into the mastoid. Now in the mastoid, there are multiple air cells. So now what will happen in the air cells is the same that was happening in the middle ear. So the mucosal lining of the mastoid air cells will become hyperemic. So all the mucosal lining of the air cells hyperemic. Everywhere there is hyperemia, and because of hyperemia, there is exudation of fluid in the air cells. Now this fluid will get suppurated. So now in the air cells, what is there is pus everywhere. Okay, so now what will happen? Because of hyperemia, there occurs decalcification. So because of hyperemic decalcification, because of the pressure of the pus, the lining of the air cells becomes thinner, 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 and the air cells, they start coalescing with each other. So now the air cells, they start fusing. The walls starts disappearing because of decalcification, because of pressure. It becomes thin, and then ultimately it goes off, and the mastoid air cells are now completely converted into a single pus-filled cavity. Gets converted into a pus-filled cavity. Right? Now where will this pus go? Because more and more of pus is still getting formed. Yes, this pus will try to escape everywhere. So where will this pus go? Yes, the most easy is that this pus will come into the middle ear. So when it comes into the middle ear, it will then go out through the external auditory canal, through the tympanic membrane into the external auditory canal. So if you're seeing pus in the external auditory canal, how do you know that this pus is not coming from the middle ear, but it is coming from the mastoid? How? Now, when it is coming from the middle ear, all the middle ear pus, once it has come into the external auditory canal and you clean the external auditory canal of the discharge, you will be able to see the perforation. You will be able to see the middle ear mucosa also, maybe through the perforation. But here, we have a reservoir of pus in the mastoid. So what will happen? The moment you clean the discharge from the external auditory canal, again immediately, no time, in that much time that you take to just clean and pick up your otoscope and have a look at the external auditory canal. Again, the external auditory canal refills with pus. Again, you clean. Again, in that much time, it refills with pus. So this tells you that there is a reservoir of pus somewhere. Where? In the mastoid. So this sign is what is known as the reservoir sign. Reservoir sign. Yes. So also, where can the pus rupture? The pus can rupture everywhere, all around the mastoid. If it ruptures superiorly, that is what is zygomatic abscess. Zygomatic abscess. If it ruptures posteriorly, that is what is known as post-auricular abscess. Post-auricular abscess. If this abscess ruptures inferiorly, yes, at the mastoid tip, tell me two muscles which are attached. Yes, one is the sternocleidomastoid, the other is the posterior belly of digastric. So if the abscess tracks down along the sternocleidomastoid, then this is what is known as bezold. And if it tracks along the posterior belly of digastric, so if it is in the sternocleidomastoid, that is bezold. If it is in the posterior belly of digastric, posterior belly of digastric, then this is what is known as Sittily. Sittily. Sittily, Sittily, Sittily. Have you heard it somewhere? Sittilies? Yes, we have heard Sittely's angle. What was Sittely's angle? Sinodural angle. Do you remember or you don't remember? Yes, when the mastoid, superiorly we have the dural plate, posteriorly the sinus plate, dural plate separating it from the middle cranial fossa dura, and here we have the sigmoid sinus. So this angle is what is known as the sinodural angle or the angle of Sittely. Do you remember now? This is the area where we have to clear the air cells to remove all the disease so that we don't leave it behind there. So that is the Sittely's angle or the sinodural angle. So this is what is Sittely's abscess. And also, if I ask you, is the posterior wall of the external auditory canal the common wall between the external auditory canal and the mastoid? I think by now it should have become a reflex. Yes, once you have seen it, it becomes so simple and you remember it. Otherwise, you used to ask me, okay, common wall is in between the mastoid and the middle ear. Now, how did external auditory canal come into picture? Yes, sometimes you send me questions that in canal wall down, we are lowering the wall between the mastoid and the middle ear. Right? Am I right? Yes, my examiner asked me that are we lowering the posterior wall of the external auditory canal also? And he was adamant that yes, we do that. So do we do that? Yes or no? Yes, we know that these are the two halls and the common wall in between them is the common wall between external auditory canal and mastoid laterally and medially middle ear and mastoid. So yes, we know that there is a common wall between the external auditory canal and the mastoid. So if the mastoid abscess ruptures anteriorly towards the external auditory canal, if the mastoid abscess ruptures anteriorly towards the external auditory canal, then in the external auditory canal, what you will see is that the posterior wall is sagging down. And this is what is known as Lux abscess. In the external aortic canal, that abscess is known as Lux. How you can remember? LUC is EAC. LUC is EAC. Lux abscess. Yes. So we are seeing now what exactly is happening in mastoiditis. So we saw that the infection from the middle ear goes into the mastoid. So the most common organism here will be the same. It will be Streptococcus pneumoniae. So now what happens in the mastoid? All the mastoid are filled with pus, and when all the mastoid becomes a common pus-filled cavity, one cavity filled with pus, that is what is known as coalescent mastoiditis. Coalescent mastoiditis. And then there can be multiple abscesses. If I ask you that most common abscess, what will be the most common abscess? Most common will be postauricular, zygomatic, bizold, Cittali. Which one? Lux. Which one? Lux? Name is nice, no? Lux. It is postauricular. The most common abscess following acute mastoiditis is postauricular abscess. And where will you give an incision in a postauricular abscess in a child less than 2 years of age? Superior and horizontal or inferior and vertical? Yes, it will be superior and horizontal. I hope you are remembering all this. Yes, this we did in the development of the ear. We always give incision postauricular, superior and horizontal less than 2 years of age. Why? Because mastoid tip develops at 2 years of age. So if you give an inferior and vertical incision, there are chances of facial nerve injury, facial nerve palsy, which now in a child where the mastoid tip is not present, the facial nerve lies just below the skin as it comes out from the stylomastoid foramen, because the stylomastoid foramen is just below the skin, not protected by the mastoid tip in children less than 2 years. Whereas in us, the stylomastoid foramen is protected by the mastoid tip. Okay, so this is what is happening. So what we just saw was what is happening inside the mastoid in acute mastoiditis. But how will this patient present to you? How will you know that this is the patient of acute mastoiditis? Yes, so you are sitting in the OPD and here is a patient who has entered the room. And just a look at the patient will tell you that something is happening behind the pinna, something in the mastoid is wrong. How? Yes, the position of his pinna. His pinna will be pushed outwards and forwards because of the edema over the mastoid. The edema, the swelling over the mastoid will push the pinna. So you will have a look at the face of the patient, face of the child, and you will see that the pinna is pushed outwards. So the moment you make the patient sit down and have a look at the postauricular area, what you will see is something like this. So what will be the appearance? In the presenting features, yes, the position of the pinna. First the pinna will be pushed outwards and forwards. You have you have a look at the retroauricular area. In the retroauricular area, what are you seeing? Yes, what are you seeing? Yes, you are seeing edema. And when you palpate it, it is very smooth, very smooth. Why? Because of subperiosteal edema. Otherwise, just feel your mastoid. Do you have the rough and bony feel? But this bony feel will go, it will appear smooth. That is known as ironed out appearance. It appears as if somebody has ironed out. So there will be ironed out appearance. Ironed out appearance, and the moment you press here, will there be tenderness? What do you think? Of course. So much of pus below, so much of inflammation. Yes, so there will be tenderness. There will be tenderness. Now, when you examine, when you have a look at the inside the ear to have a look at the external aortic canal and the tympanic membrane. So, when you see inside, what do you see? Yes, if the pus has ruptured towards the external aortic canal side, you will see that the posterior wall of the external aortic canal is sagging down. So, you will see sagging of which wall of external aortic canal? Posterior wall. This is the common wall between external aortic canal and mastoid. So between the sagging of the posterior wall of external auditory canal, and also if there is pus in the external aortic canal, will you be able to make out it is coming from the middle or it is coming from the mastoid? Yes. What sign? Reservoir sign. Clean it, again refills. Clean it, again refills. So you will see in the external aortic canal also the reservoir sign. So you have a child who has come to you with this complaint. You see the retroauricular area, you see the ironed out, you see there is tenderness, external aortic canal, you have a look, and maybe there is an abscess that you are seeing. How should we manage this patient? What should we do? We know what the pathology is. What is the pathology? If the abscess is formed, then okay, we can drain the abscess. But if the abscess is not formed, yes, if the patient has come to you when there is, you're not sure that the abscess, the pus is there, but where is the pus in the air cells still? It is not coalesced and it has not formed one cavity, one abscess cavity. So now what will you do? We have to remove pus. Whenever there is pus, we have to remove it. How will we remove the pus from the mastoid air cells? Open them. How do you open them? Yes, you give a post-auricular incision. What is that known as? Wild's incision. And you start drilling. You start drilling. As you go on drilling, all the mastoid air cells get opened, and as the air cells are opened, all the pus from inside it goes on coming out till you have reached the mastoid antrum. You have opened all the mastoid air cells. You have removed pus from all the mastoid air cells. This simple just going on drilling to remove the pus is what is known as simple mastodectomy, cortical mastodectomy, or Schwartz operation. So what do we do here? Let's see. So we give the Wild's incision. We drill the mastoid. Yes. And we open all the mastoid air cells till we have removed pus from everywhere. This is what is known as simple mastodectomy. Also known as cortical mastodectomy. All you're doing is just opening the cortex. Simply drilling, or also known as Schwartz operation. Yes, but it is also possible when the patient has come, the inflammation is not too much. Yes, and you're not sure that the pus actually requires draining. Maybe if the pus is little, it might improve just by medical management. But we are not sure whether medical management will work or not. But then what is the harm in giving medical management? So first, always give medical management. Give medical management with antibiotics at least for 48 hours. So when we write the management will be first medical. Medical management you will give if it is benefiting, if the patient is responding, very good, wonderful, continue it. But if it is not responding within 48 hours, yes. So if no response in 48 hours, then you go for surgery. What surgery is this? Yes, then you go for simple or cortical mastoidectomy, or also known as Schwartz operation. Yes, so that is the surgical part. So do you know what is happening in mastoiditis? Yes, do you know when you will think of mastoiditis, you are sitting in the OPD, what appearance of the pinna? Outwards and forwards. What appearance of the mastoid? Ironed out appearance. External aortic canal, what appearance of discharge? Reservoir sign. Yes, all this make you know that this is mastoiditis. And if it is mastoiditis, first management, medical. Not responding for 48 hours, surgical. What surgery? Schwartz operation. Also known as simple mastectomy, also known as cortical mastectomy. Now just have a look at this picture. Is this acute mastoiditis? Is this looking like inflammation of the mastoid? Yes, this is post-auricular. This is red, but this is appearing clearly like a bruise, right? Yes, this is like a laceration. This is like a bleeding that has occurred. Yes, so don't confuse this with mastoiditis. This is the typical appearance of mastoid following basilar skull fracture, base of skull fracture, fracture of the temporal bone, and this is what is known as battle sign. This is known as Battle's sign. And in this patient, when you examine the external aortic canal for looking for the tympanic membrane, you will not see reservoir sign. You will not see the inflamed tympanic membrane. What you will see will be hemotympanum. So the bluish tympanic membrane, hemotympanum. So this is, don't confuse this appearance as mastoiditis. Is that clear? Now we know that the mastoid air cells communicate with the petrous group of air cells. So when the infection from the mastoid goes into the petrous part of the temporal bone, reaching up to the petrous apex, that is what we call as petrositis. So what is happening in petrositis is ditto as mastoiditis, ditto as acute otitis media. The only difference is the location. So here when the infection from the mastoid goes to the petrous group of air cells. Yes. So in the petrous, there are multiple air cells, but not in everybody. Only 30% individuals have a very well pneumatized petrous bone. So now what happens when the infection goes here? Same. See, ASOM, acuratitis media, you told me, mastocytitis, I told you. Now this also you will tell me. Tell me what is happening. Okay, first, very good, hyperemia, hyperemia. Yes, hyperemia. Next, okay, presuppuration, all the petrous air cells filled with fluid. Next, very good, yes, suppuration. So now all the mastoid air cells are filled with pus. Now they will start applying pressure, there will be hyperemic decalcification, and all the air cells will coalesce to form pus, which will reach up till the petrous apex, and this is what we call as petrositis. This much I will tell you. Next, you will tell me. Tell me, if the infection reaches up till the petrous apex, which cranial nerves will be involved? So, which are the cranial nerves at the petrous apex? Yes, here we have the Meckel's cave. Which nerve there? Fifth nerve. Here, from the apex passes which nerve? The sixth nerve. So, yes, there will be fifth nerve involvement. And there will be sixth nerve palsy. Along with persistence of your discharge. Persistence of your discharge. And this is what we call as Gradenigo's triad. This is known as Gradenigo's triad. Very good. But this will be asked as which of the following is a feature of Gradenigo's triad, which is not a feature of Gradenigo's triad. If it is given in clinical presentation, what will be the finding? If it is Gradenigo's triad, yes, there will be persistence of your discharge. Very good. I will tell you fifth nerve involvement. You tell me what feature of fifth nerve involvement. If there is involvement of fifth nerve, what will be the presentation? Fifth nerve, trigeminal. What branches? Ophthalmic, maxillary, mandibular, sensory. Yes, so there will be retroorbital pain. There will be paresthesias over the face. So because of fifth nerve, there will be retroorbital pain. There will be paresthesias. Sixth nerve. Because of sixth nerve, what will happen? Sixth nerve palsy will lead to what? Sixth nerve supplies what? LR6. LR6 is what? Lateral rectus cyst. Lateral rectus cyst will be, yes, it will lead to diplopia. A patient of chronic otitis media presents with persistence of ear discharge following mastoid surgery, and there is diplopia. So most probable diagnosis is, yes, so you have done a mastoid surgery, you have opened up all the mastoid air cells, you have removed the disease from everywhere. Now if the pus is coming, it is coming from where? From petrous. And diplopia tells you which nerve? Yes, sixth nerve. Is the sixth nerve anywhere inside the ear, in the external aortic canal, in the middle ear, in the inner ear? If there is diplopia because of the sixth nerve involvement, if there is diplopia, we know that it can be because of, in the ear, it can be because of the sixth nerve involvement. And where is the sixth nerve in relation to the ear? Yes, that is at the petrous apex. So we know whenever there is any such presentation, involvement of the fifth nerve, there is palsy of the sixth nerve, then this is petrositis. Now, it has been asked, which of the following is feature of Gradenigo's triad? Palsy of the fifth and sixth nerve, yes or no? One of the choice was palsy of the fifth and sixth nerve, yes, no? No, fifth nerve is just involvement. Why not palsy? Why don't we call that as palsy? Because fifth nerve has 3 branches. So, it is not necessary that all the 3 will be involved. So, it is called as involvement. Or if I say, was a question asked in your exam when it was asked, one of the choices was, in Gradenigo's triad, which of the following is true? And one of the choices was, there is involvement of fifth and sixth nerve. Will that be true? Palsy means involvement. Yes or no? Palsy means involvement, but involvement does not mean palsy. Yes. So this is what is petrositis. A patient of chronic otitis media presents with a patient of acute otitis media presents with diplopia, as it is shown in the figure, and a HRCT of the temporal bone was done, which is given below. So can you tell me by the picture and by this what you are seeing here? What are you seeing here? In this patient we are seeing that which eye is not moving? Yes, this is the right, this is the left. Left is not moving laterally. Can you see this is moved lateral? There should be conjugate movement. This is not moving. So yes, there is left lateral rectus palsy, and also what we are seeing is left lateral rectus palsy, and also this is, yes, now by now you know very, very clearly how to see the where the ear is, that is the temporal bone. So this is the petrous part of the temporal bone. We can see all the air cells, all inside should be air. Here everything is just fluid filled up till here. The petrous, we can see up till the apex there is just, if it is filled with air, just see here. Yes, here this one is the disease site and this is the normal. Can you see it is usually filled with air? It appears black. See the petrous part also of the temporal bone, it is black, and on the other side here, in this case, in the right side, it is all filled with pus. So this is the typical presentation. What is this? What is the diagnosis? This is petrositis, and what is the triad known as? Gradinigos triad. This is the Gradinigos triad. So quickly tell me, what are the intratemporal complications of otitis media, acute or chronic otitis media? Intratemporal, quickly tell me. Yes, when the infection, if it goes laterally, perforation. Medially, labyrinthitis. In the fallopian canal, facial nerve palsy. Posteriorly, mastoiditis. From the mastoid to petrous apex, petrositis. Reservoir sign is seen in reservoir sign. The moment you hear reservoir, remember reservoir of pus somewhere. Pus where? In the mastoid. Yes, mastoiditis. Most common organism causing acute mastoiditis is Streptococcus pneumoniae. Most common abscess following acute mastoiditis. Acute mastoiditis, most common abscess is post-auricular. The abscess following acute mastoiditis in relation to the sternocleidomastoid is Bisold. In relation to posterior belly of digastric is Sitley. What is Sitley's angle? Sitley's angle is sinodural angle. What is Schwartz surgery done for? Schwartz surgery. Schwartz surgery is also known as simple mastodectomy, also known as cortical mastodectomy. It is done for acute mastoiditis. The involvement of fifth nerve, palsy of sixth nerve, along with persistence of ear discharge in a patient of chronic otitis media following mastodectomy. There is persistence of ear discharge. There is fifth nerve involvement. There is sixth nerve palsy. This suggests, yes, Gradinigos triad. That is Gradinigos triad. What is the most common intratemporal complication following acute otitis media? Perforation. Following chronic otitis media, mastoid abscess. Now coming to the intracranial complications. So what are the intracranial complications? So here we have the mastoid. This here is the mastoid here. Superiorly, we have the dural plate. We know that we have the dural plate. This is the plate of bone separating the mastoid from the dura of the middle cranial fossa. So here we have the dura of the middle cranial fossa. So we have the dura, we have the arachnoid, we have the pia, yes. And posteriorly, what do we have? We have the sigmoid sinus here. This is the sinus plate. This is the sinus plate. So now the infection from the mastoid can go superiorly. If it goes superiorly, what will happen? What all can it lead to? So if it goes superiorly, it can lead to a abscess outside the dura. So there can be a extradural abscess. Extradural abscess. Yes. Now there can be, then it can go below the dura, right? So there can be a subdural abscess. Subdural. Next, it can go below the arachnoid. What is that space? Yes, that is the subarachnoid space. So that can lead to meningitis. There can be meningitis. Then it can go into this part of the intracranial cavity. What is this lobe? Yes, the temporal lobe. So then there can be temporal lobe abscess. temporal lobe abscess. So if it goes superiorly, this is how we are going to remember. Extradural, we remember in a orderly fashion. These complications that we are remembering in the orderly fashion do not occur in the same order. But we are going to remember it like this so that we do not forget. So extradural, subdural, meningitis, temporal lobe abscess. The most common is meningitis. Meningitis is most common. Most common is meningitis. Most common autogenic brain abscess is temporal lobe abscess. This is the most common autogenic brain abscess. Autogenic brain abscess, which means brain abscess because of ear infection. If it is the most common autogenic brain abscess, it means that can we have any other brain abscess also? If we go on going medial to the medialmost wall of the antrum, of the masted antrum, what do we have? Yes, we have the posterior cranial fossa. We have the cerebellum. So this is the most common brain abscess is temporal, followed by cerebellar. Followed by cerebellar. So cerebellar is second. Most common autogenic is temporal lobe abscess. Now when the infection from the mastoid goes posteriorly, it can erode the bone, the sinus plate. It can lead to an abscess all around the sigmoid sinus, and then it can lead to damage of the endothelium of the sigmoid sinus and ultimately resulting in a thrombus inside the sigmoid sinus. So this is what is known as sigmoid sinus thrombosis. Sigmoid sinus thrombosis. Thrombosis. Yes, the sigmoid sinus, we have the straight sinus that forms the lateral sinus, that is the transverse sinus, and then the sigmoid sinus. So sigmoid sinus thrombosis can progress to the lateral sinus also, that is the transverse sinus also. So it can lead to lateral sinus thrombosis also. So these are the intracranial complications. So in the intracranial complications, quickly tell me. Yes, extradural, subdural, meningitis, temporal lobe abscess, or sigmoid sinus thrombosis. Most common, meningitis. Most common brain abscess, temporal, followed by cerebellar. So how will you know any patient of otitis media is now presented with a temporal lobe abscess? Will there be personality changes? Personality changes. Do personality changes occur in temporal lobe abscess? No, they occur in frontal lobe abscess. So in temporal lobe abscess, what is the feature? Nominal aphasia. What is nominal aphasia? You show him this and you ask him what is this, name this. He will tell this is used to write. He will not be able to name it as pen. So in temporal lobe abscess, naming is not there. That is known as nominal aphasia. So there is nominal aphasia. Nominal aphasia. Very, very important is fits, convulsions. Convulsions. Always in patients of convulsions, when the EEG is showing increased activity, always it is increased activity in the temporoparietal lobe. So this is the temporal lobe is the very important area for the site of origin of convulsions, of fits. So yes, this is a very important feature. Along with that, a very important feature is some defect of vision. Which defect of vision? Yes, in one quadrant in both the eyes, patient is not able to see anything. What is that known as? Yes, that is known as in one quadrant. As you are seeing here, patient is not seeing anything. Hemianopia, quadrantonopia in one quadrant. Quadrantonopia, that is homonymous supraquadrantonopia. This is known as pie in the sky appearance. That is how we remember temporal lobe is sky, pie in the sky. Whereas pie in the floor is seen in parietal lobe. So this is pie in the sky. So here we see the pie in the sky appearance in vision. And along with that, there is contralateral motor palsy. Contralateral motor palsy. A patient of chronic otitis media now presents with convulsions. I'm not asking the diagnosis. Diagnosis we know is temporal lobe abscess. Okay, so his CT shows a ring enhancing mass. This was a question asked very recently. There was asked the diagnosis. So yes, diagnosis we know is a temporal lobe abscess. What I'm asking you is the management. Tell me the management of this patient. A patient is presented with otitis media with convulsions. Convulsions itself, that much is sufficient for you to diagnose that this is a temporal lobe abscess. CT is also given, and CT is showing the ring enhancing mass. So this diagnoses that yes, this is a temporal lobe abscess in the temporal lobe area. So how are you going to manage this patient? MRM? MRM. Yes or no? Abscess drainage. We have to remove the abscess. Now abscess anywhere has to be drained. Abscess drainage, MRM. It has led. What is the management of unsafe otitis media? What is the management of unsafe otitis media or squamous otitis media with complication? What is the management? MRM. Yes or no? Yes. Intact canal wall down surgery, extensive disease, canal wall down surgery. So yes, here you will do MRM, you will do abscess drainage, and look at the choices. Abscess drainage followed by MRM. MRM followed by abscess drainage. What will you do first? Abscess drainage first. Why abscess drainage first? It is a brain abscess. Yes, so you do not want to for the further deterioration to occur. So the intracranial complication always has to be managed first. So you will go for abscess drainage first, and once the abscess drainage has been done, then you go for MRM. And then you ask me that, okay, if the cause is in the mastoid, why are we doing it after intracranial abscess drainage? So it is not that we have drained the abscess and after 6 months, after 1 year, after 2 years, we will do MRM. It is once the patient is stable. So you have done a abscess drainage. Maybe in 3 days, in 5 days, the patient is stable. Then you can take up the patient for MRM. So it is, the management is abscess drainage, followed by MRM. When the infection goes posteriorly, where does it go? Yes, into the sigmoid sinus, and we just saw that there can be a perisinus abscess, there can be intrasinus abscess, and there can be intrasinus thrombosis. And that is what is known as sigmoid sinus, or it can also go into this lateral sinus or lateral sinus thrombosis. Now here, whatever is occurring in sigmoid sinus thrombosis is because of the thrombus. So whenever a question of sigmoid sinus thrombosis comes, or whenever we think of sigmoid sinus thrombosis, what should we remember is thrombus. Thrombus where? At 3 places. First is in the main sigmoid sinus. The sigmoid sinus, when it comes out from the jugular fossa as jugular bulb, that is in relation to the floor of the middle ear, this area, we know that. And then it goes down in the neck. In the neck, what does it form? Yes, the internal jugular vein. That is the internal jugular vein. Okay, so now where is the thrombus? Superiorly, there is a tributary of the sigmoid sinus which is responsible for draining the mastoid. So now either there can be problem because of thrombus inside the main sinus, sigmoid sinus, or if it goes embolizes superiorly, it can go into this vein, tributary, which is responsible for draining the mastoid. This is what is known as the mastoid emissary vein. This is the mastoid emissary vein. What will happen? If there is thrombus in the mastoid emissary vein, what will happen? What can happen? Yes, that is responsible for drainage of the mastoid. Mastoid drainage will not happen. If the mastoid drainage will not happen, there will be edema of the mastoid, venous congestion. So this venous congestion will make the mastoid appear a little congested, and will there be tenderness? Yes, there will be tenderness. So here this will lead to mastoid congestion and tenderness. Congestion plus tenderness. Are you thinking something? Mastoid tenderness, mastoid congestion, was it seen in any other condition also? In mastoiditis also, but will reservoir sign be seen here? Reservoir sign here? No, there we were seeing reservoir sign. There we were seeing sagging of posterior wall of external aortic canal. Here we are not seeing all this. Yes, here what is happening is there is mastoid emissary vein obstruction, because of which there is tenderness over the mastoid. There is edema over the mastoid. And if the thrombus goes inferiorly, where does it go? It goes into the internal jugular vein. So what will happen when the internal jugular vein gets obstructed? This is something more severe. Internal jugular vein, what does it do? It is responsible for venous drainage of the complete one half of the face, one side, one half of intracranial also. Yes. So what will happen if the internal jugular vein gets obstructed? One side venous drainage completely blocked? No. What happens? Yes, as it is getting blocked, collaterals form. And the opposite side, which is the normal side, takes up the function of the abnormal or the obstructed side also. Which means in this patient where one jugular vein is obstructed, the only functioning will be the other, that is a normal jugular vein. This patient will come to you with a complaint of very severe pain. There is thrombus inside the jugular vein. Jugular vein is a good vein, yes. So there is thrombus inside it. So this jugular vein becomes very hard cord-like. It becomes cord-like. It becomes cord-like, very, very, very painful, very tender, very tender. You are examining the patient is telling, I'm having very severe pain here. You are examining, patient is wincing of the pain. He's not letting you touch. So you feel so much of pain in the neck. Okay, so you see the oral cavity, oropharynx, larynx, everything normal. So then you make the diagnosis, patient is hysterical. Why? Because so much of pain in the neck. And when there is pain in the neck, all you can think of is oral cavity, oropharynx, you can think of larynx. But no, you are not thinking of the ear. Why? Because the patient is not telling you about the ear. Why is not telling you about the ear? Yes, because usually this will follow a chronic otitis media and he is used to the discharge. That is not troubling him very much. Now what is troubling him is the severe pain. Yes, so any patient with severe pain in the neck area overlying the jugular vein, always examine the ear to rule out which condition? To rule out a sigmoid sinus thrombosis following otitis media. So here, how will you know in this patient that there is severe pain here? This is obstruction of the jugular vein. How will you know? Yes. If there is obstruction of jugular vein of one side, the other is the only functioning. So if the only functioning jugular vein we block, will there be a sudden increase in CSF pressure? Yes. Can you see the sudden increase in CSF pressure sitting in the OPD? In the OPD? OPD itself? Yes. How? Yes, you by ophthalmoscope. So you take out your ophthalmoscope and you have a look in the eye. You press the opposite side which is appearing to be normal, and if this is the only functional, there will be a sudden papilledema in the eye. There will be retinal vein engorgement in the eye, and that is what is known as Crowe-Beck sign. Crowe-Beck sign. What is this Crowe-Beck sign? This is papilledema. Papilledema on pressing the normal jugular vein, normal internal jugular vein in sigmoid sinus thrombosis patient. Yes, so if there is one sinus, if in jugular vein thrombosis, in sigmoid sinus thrombosis leading to IJV thrombosis. And this increase in CSF pressure, you can also see, yes, just see here. We have this papilledema. This is the Crowe-Beck sign. Crowe-Beck sign. And the same, you can also see the same increase in CSF pressure by pressing the normal. You can also see while doing lumbar puncture. While you're doing the lumbar puncture, suddenly press this. So if the other one is obstructed, this is only functional, this will lead to a sudden increase in CSF pressure that you will be able to measure while doing the lumbar puncture. So if you see the increased CSF pressure on lumbar puncture, then this is what is known as Tobbe-Ayer test. Tobbe-Ayer, also known as Queckenstedt's test. So whenever you think of a sigmoid sinus thrombosis, or whenever an equation of sigmoid sinus thrombosis is given, immediately this picture should come to your mind with thrombus at three sides. Yes. So the main thrombus is in the sigmoid sinus, What will happen because of that thrombus? We have done that if the thrombus goes superiorly into the mastoid emissary vein, what will happen? If it goes into the internal jugular vein, what will happen? We have seen that. Now let us see what this main thrombus at the sigmoid sinus can do. Yes, this thrombus here will get released as embola into the systemic circulation. So whenever there is a release of the embola into the systemic circulation, there will be a peak of fever. Patient will be then again fine. Again, after some time, again another release of the infective emboli, again another peak of fever, again fine. What is this type of fever known as? This is known as picket fence. Picket fence, like a boundary wall. Picket fence or hectic type of fever. Hectic type of fever. Yes, so when you think of sigmoid sinus thrombosis, this complete picture should come to your mind with the thrombus main in the sigmoid sinus, embolus going to the mastoid emissary vein, embolus going below to the internal jugular vein. Quickly tell me that mastoid emissary vein obstruction will lead to edema over the mastoid. Yes, and the jugular vein obstruction will lead to cord-like internal jugular vein, very tender internal jugular vein. The thrombus in the sigmoid sinus will lead to, main sigmoid sinus will lead to hectic type of fever. Yes, edema of the mastoid is seen in any other condition you know of other than sigmoid sinus thrombosis in mastoiditis. In mastoiditis, what was the appearance of mastoid known as? Very smooth, edematous, ironed out mastoid. And here, this edema of the mastoid with congestion because of venous congestion because of obstruction of mastoid emissary vein is what is known as, this is known as Grisinger's sign. Grisinger's sign. Just remember, Grisinger's is greasy feeling, smooth appearance. That is edema of the mastoid, Grisinger's sign. Grisinger's sign. So that is what happens in sigmoid sinus thrombosis. Gradinigo striae is seen in Gradinigo striae, Pitrositis. Grisinger's sign, sigmoid sinus thrombosis. Ironed out mastoid, mastoiditis. Reservoir sign, reservoir, mastoiditis. That is mastoiditis. Krobeck sign, Krobeck. What is Krobeck? Papilledema in the eye. Yes. Now, whenever this patient is presenting with all this, will you like to get some investigation done? An HRCT of the temporal bone or of the an MRI? Yes, to see the sinus? Yes, you will get it done. And what you will see will be, you will see a thrombus at any, you can see it here, you are seeing at the junction of the straight sinus with the transverse sinus. You are seeing it here, this thrombus that you are seeing. Yes, you can see it anywhere. You can see it anywhere along the sigmoid sinus or over the over the lateral sinus. Anywhere you will see this appearance. This appearance, what is this appearance known as? This is known as delta sign or empty triangle. Why empty triangle? The thrombus does not take up the contrast. The walls appear like an empty triangle. So it is known as an empty triangle or a delta sign So will you be able to diagnose if the patient comes to you of otitis media with a sigmoid sinus thrombosis? Yes. Patient will have what complaint? Very severe pain over the neck, overlying the jugular vein. Edema of the mastoid with reservoir sign. If there is edema of the mastoid with reservoir sign, then your diagnosis will be mastoiditis. If there is edema of the mastoid with jugular vein area tenderness, then it is sigmoid sinus thrombosis. And sigmoid sinus thrombosis patients will have what fever? Yes, peak of fever coming down. Peak of fever. What is that known as? Hectic type of fever. Also known as picket fence fever. Picket fence fever. Can you find out in the OPD itself by seeing that this, by examining that this is the obstructed jugular vein, this is the normal jugular vein? Yes, with signs. Yes, as papilledema in the eye. What is that known as? Krobeck. Increase CSF pressure on lumbar puncture. What is that known as? Tobbe-Ayer test. Now, if you have treated a patient of sigmoid sinus thrombosis, the patient has become non-infective now. But one of the embolus which is now non-infective, it goes and it lodges in any other cerebral vein. For example, if it goes into the superior parietal sinus, if it goes into the inferior parietal sinus, if it goes in any of the sinuses, then what it will do is it will block there. It will cause obstruction. That will lead to, yes, there we have the arachnoid villi. So absorption of CSF will be hampered. That will lead to hydrocephalus. That will lead to increase in the CSF. This is what is known as otitic hydrocephalus. Otitic hydrocephalus, how will the patient present? Patient will not have any features of infection because you have treated the patient. It is a non-infective emboli which has now gone and lodged into one of the sinuses. So patient will have features of intracranial hypertension. Patient will have increased features of hydrocephalus, headache, vomiting, all features of increased intracranial tension. But when you do a lumbar puncture, the CSF findings will be normal. So when does usually such appearance occur? That there is increase in the pressure of CSF, but the finding of CSF is normal. It means that there is no abnormality inside the CSF. Where is the problem? It appears like there is a tumor outside which is compressing, leading to increase in CSF pressure. So this is also known as pseudo-tumor cerebri. Why? Because this is actually not a tumor. It is mimicking what will happen when there will be a tumor. So this is pseudo-tumor cerebri. This is mimicking how a tumor presents with. So this is pseudo-tumor cerebri, or it is known as benign intracranial hypertension. Benign intracranial hypertension. So now you can keep your pens down, sit straight. Yes? Okay. So what is the most common intratemporal complication of acute otitis media? Perforation. Okay. Most common intracranial complication of otitis media is meningitis. Most common brain abscesses, temporal lobe abscess. Most common complication of chronic otitis media is mastoid abscess. Most common mastoid abscesses. Most common abscess. Falling mastoiditis is postauricular. In relation to sternocleidomastoid mastoid is Bizold abscess. A patient of otitis media presents with reservoir sign and tenderness over the mastoid. Tenderness over the mastoid and reservoir sign. What is the diagnosis? Mastoiditis. Patient presents with edema over the mastoid and jugular vein tenderness. Jugular vein tenderness. Sigmoid sinus thrombosis. This edema of the mastoid when there is jugular vein thrombosis also in this patient. What is this edema of the mastoid known as? Grisinger's sign. Grisinger's sign is because of obstruction of. Yes, that was another question of your exam. Mastoid emissary vein. A patient of unsafe otitis media or squamous otitis media now presents with diplopia and pain in the eye or pain retroorbital. Diagnosis is, yes, pitrositis. What is this triad known as? Gradenigo's triad. This is Gradenigo's triad. So these are the complications of otitis media, be it acute otitis media, be it chronic otitis media, that we need to know, and these are very, very commonly asked in our exams.